Welcome to Interoperability Roundtable. This is an open forum fostering conversations around healthcare, data, and innovation. My name is Jake Tunney, Director of Payer Solutions at Leap Orbit, and I'll be your MC today. We're joined today by host David Finney, co-founder of Leap Orbit. Leap Orbit is the trusted innovation partner to many of the biggest market-leading health data networks, including CRISP, Manifest Medics, Sync Health, as well as the policymakers who oversee them. Leap Orbit is the parent company of Convergent, a next-gen provider data management solution that ensures accurate, automated provider data for some of the leading health plans, HIEs, and state exchanges across the country, including Priority Health, the Washington Health Benefit Exchange, and many more. Today, we are joined by our esteemed guest, Jon Hamdorf, Market President of UCare. UCare is an independent nonprofit health plan providing health coverage and services across Minnesota and Western Wisconsin. Jon has expertise in health policy and management and healthcare IT, with measurable success accelerating growth for health plans by implementing solutions that improve the provider and member experience. Jon is an empathetic leader, all-around great guy, absolute beast in the weight room. I think he can squat at least two of me, and that's saying a lot due to the amount of bagels I've been eating lately. Got to lay off those. We've got a great agenda for today covering provider data strategies for growing health plans, how this always relates to health equity and the member experience, and as well as some of the blocking and tackling around technology decisions that enable plans to be effective at implementing these strategies. So Jon, we wanted to cue this topic up by starting at the heart of this conversation, which obviously will include a large component around providers, but we wanted to really start with this in the context of member experience and health equity. So can you help me set the table here with that in mind?
Sure, Jake. Thank you very much. Thanks for the introduction. Thanks for inviting me. I've had kind of a unique perspective, I think, on the member aspect of these scenarios, because I did serve as Kansas Medicaid director for multiple years. Had a chance to work with a lot of the individuals on the program that interacted to try to find providers, try and find services. It also gave me the opportunity to work with 4 health plans, 3 of them in the Fortune 25 range that all had different solutions in the space. And finally, just as a consumer myself, interacting with the tools that my health plan provides me on a day-to-day basis. And I guess the perspective I'd like to bring this from is like that first engagement, that first interaction, that first experience with a health plan when you're searching for to see if your provider is covered, or maybe you're searching for just a need outside of your regular day-to-day health routine. And as you go into that experience, as you go into the health-related tools and provider directories, the thing I've noticed is they're just not very good. Really across the board, whether you're talking about the private side or the public insurance side. I don't feel the companies have really taken this opportunity to recognize this as an engagement with their member. So what happens? A member comes in, they're probably feeling some anxiety, probably some concern because they're searching for a provider, which means they have a health need. If they have difficulty at that point in time, engaging with those tools, if they don't meet their needs, then they essentially go down one of 2 paths. One path is they just retreat and they just bypass the service, which would lead to maybe a worsening of whatever the condition is and more expenditures down the road. Or they have to engage the health plan in a different way, which means calling to the call center. That brings up another whole host of things and introduces compliance issues as well as contract issues of, is the phone being picked up fast enough? Is it time to resolution fast enough? Again, we're engaging, we're taking up health plan resources. These things could be sidestepped if there was a really compelling, easy use, customizable tool at the front end for the patient to engage to find a provider in their network. And it's always baffled me why health plans have looked at these tools as a liability when they could really be an asset. So I guess from the member side and the equity side, um, the member's looking for a customized experience. They're looking for something that is personalized to them. So, for example, the frame of health equity, um, maybe I want a provider that has the same demographics that I am. Maybe that would make me feel more comfortable. Maybe as a woman, I want a female provider. A lot of these tools don't provide that customization because it's not required by CMS and because it's so difficult to have to code something unique for one particular product line. So they don't have the freedom and the flexibility to customize that experience for the end user. And that's where healthcare is going. We keep hearing that personalized medicine, personalized experience, customer satisfaction when it comes to, star ratings for Medicare. So I think this is going to be a great conversation today. I have so many thoughts on this. I don't want to dominate the conversation. I want to give David a chance as well, but thanks for indulging me and letting me kind of share that experience of, working with Medicaid populations and then being in the private space and then having that background of mine. So thanks, Jake. David?
Absolutely.
Yeah, no, John, I'm excited to have this conversation with you. And based on the remarks you just made, we could probably shoot off in 100 different directions. But I think one of the things you hinted at or you spoke to is that the provider search experience is kind of a critical part of the front door or the storefront of a health plan. Why do you go to a health plan's website? Why do you log into the portal? Why do you pick up the phone and call customer support? A lot of times it really is about the interface between the member and the network, right? Because they've got an issue, they're looking for care. They've been trying to call a doctor and they can't find one who agrees to see them. And so it really is kind of critical. Whereas it's always amazing to me how provider data kind of people perceive it as this issue that sits in the back office. And it's there's sort of the behind the curtain, sausage grinding stuff that nobody cares about, but it really does drive a lot of the things that are important to the customer experience.
Yeah,
Go
ahead.
No, you hit on star ratings for Medicare products, and this has been something that I've kind of been thinking about a lot recently. The CAHPS measures, there are a bunch of them that are directly relevant to the network and provider data. If you think about survey questions around access to care and the ability to get appointments, the small changes in the survey results for some of those measures can drive potentially really meaningful changes in the overall star rating for a plan. And even more so kind of going into next year, because from what I understand, CMS has doubled the weighting of those particular elements in the overall, the overall score.
No, I agree.
One interesting thread here too, I want to point out. I think there's a direct link between provider experience and member experience. And what I hear from you, John, a lot of times there ends up being some provider abrasion or provider attrition due to bad experience with the plan, and that ends up affecting, some of the most vulnerable populations. So can we explore that for a bit and sort of help me understand how that link is created and what we might be able to do about that?
Sure. I recently attended a National Association of Medicaid Directors meeting that was just this week in DC, actually. And one of my colleagues, a guy named Jay Ludlam from North Carolina, was talking about why North Carolina moved from a fee-for-service system where essentially the state directly pays the claims of the providers to a managed care system where you have insurance companies kind of serve as that intermediary, on their behalf to pay claims and interface with providers and with members. And I still remember so clearly what he said. He said, we thought that we were purchasing a revolutionary experience for our providers and for our members. What we actually got was post-pay review. And I guess he said it a little tongue in cheek and a little bit snarky, but I agree. I mean, the idea was that North Carolina was going to outsource this capability to, again, like Fortune 5, Fortune 25 companies that have immense expertise, immense assets, access to resources, because he wanted those providers that serve the most, at-risk members or at-risk citizens in North Carolina to have a wonderful experience. And he wanted to make sure that the providers who are being compensated significantly less for serving Medicaid at least didn't have to deal with all the administrative hassles. And they got neither one of those. They essentially got more administrative hassles for these providers and no increase in their reimbursement, which is really a step backwards. And that's where I think we start getting into trouble in the health system when we don't realize that resources are fixed. Like we can't generate more time in the day. And if we're asking our providers to spend more and more time doing administrative things, then they're not going to be able to do some other really critical things, such as keeping their provider data up to date. And that affects, like what David was saying, earlier, it affects the entire chain, the entire healthcare ecosystem. The reason why it does that is if their data isn't up to date, then that affects the member in the front end trying to find them. If their data isn't up to date, that affects the claim payment on the back end as we're trying to, adjudicate claims. It affects every step along the system when we take up so much of their time doing other administrative things, because they're supposed to be seeing patients. Some providers in my own backyard that I meet with regularly tell me, that they're operating at about a 65 to 70% efficiency rate. That means they're spending almost over 30% of their time doing administrative things. This goes directly into the workforce conversation. Like, how do we grow workforce? Well, if we can't grow workforce, how do we optimize workforce so we're spending less time doing administrative things and more time delivering care? And how do we take those administrative duties and really identify which ones are the most important ones? And I would argue, I think provider data is one of those things that people put, like David said, in the back office and don't even consider it as part of the care conversation, where it really should be in the forefront of the care conversation. If the data isn't correct, the member can't find the provider can't get paid. That directly affects the hospital or the clinic's revenue. It affects the member ability to access resources. And it just has a ripple effect that scrolls throughout the health system. So I think it's just a critical conversation we should be having right now that we're not. It's not quite in the forefront.
Jon, in your current role, as I understand it, part of what you're charged with is, expanding into new markets, and new regulated markets, right? So across borders. Does that give you? How do you think about that in terms of this question of sort of network building and the provider experience? Is that part of the pitch as you go out and try to build a new network?
Oh, it is. I think with the company I'm with now, with UCare, we're a nonprofit, community health plan. So, we're not like I said, the gigantic health plans. We're not the Aetnas, Humanas, Centenes of the world. And our approach is different because of that. We're not coming into states and saying, we're going to drop our national model on you and you'll have to adhere to it. Mm-hmm. We're going into these markets saying, how can we provide you a customized experience? And I think that is so critical to smaller health plans, because you can't play the big health plan game. You can't just overwhelm them with size and structure and technology and all these other things, but you can be smarter. The thing that always blew me away with when I was Medicaid director with the health plans I worked with, they couldn't do anything quickly. Like if we wanted, for example, let's take a provider directory type question. if we wanted to add ethnicity and have the provider provide an ethnicity so that we could provide a tool to our members in the health equity kind of focus, that if they wanted a provider of their same ethnicity, they'd be able to see that on their provider directory. I mean, the feedback I got from these folks is like, oh, it'll take $30 million and we'll have to get approval from every single market we're in, and it'll be a development effort. And I'm sitting there like, are you serious? You are not more nimble than this. You can't just say, I'm going to configure what's visible to this product in this market, and that can be different than what's visible to this product in the same market or even this other market. I mean, the way that Medicaid works is every single state is different and unique. And you have a set of CMS regulations that everybody has to adhere to, but then you have contract regulations and state regulations that you have to support. So you have to be able to customize at that local level. And that's where we play. That's where the smaller players play. That's where we can thrive. That's where we can win. The analogy I like to present is, I think back to basketball. I like sports, but when you think back to the way the game of basketball used to be played, you used to have 3 or 4 big guys, the 2 or 3 big guys in the middle, and they would dominate the paint. And if your team didn't have big guys, you couldn't go play that game. You couldn't go play the post game with them because you're going to get killed. So what do? You run. You shoot 3-pointers. You play your game. You kind of take that Golden State Warriors approach to it. And guess what? That's how you win. You win by playing your game and not by playing their game. And I firmly believe that if health plans can partner with technology companies that make them more nimble, more agile, not only can they respond to market needs quicker, but also they're taking those dollars that they would have spent in their development shop and they're putting it towards something that brings value to the member. Spending development hours doesn't do anything for members. If I spend 4 weeks developing something, all that time, all those resources I could have been putting towards a community event. I could have been putting towards a baby shower. I could have been putting towards a value-added benefit. I can re-task those employees to do high-value items instead of low-value items. Seriously, like that's some of the feedback I got, like the development times of 90 to 120 days. When I'm thinking, if this was configurable, it'd take about 10 minutes. You'd go into your test environment, you'd set it, you'd run a couple test scenarios, you'd validate it, you roll it to prod. There we go. Why are we making this so hard?
Well, yeah, I mean, Jake and I have a colleague who calls this the hand-to-hand combat, and it's sort of the members don't always see it, but the plans and the providers are in constant sort of bare knuckle combat on just basic administrative back and forth, right? Like we have a customer, a health plan who just has major issues with directory accuracy. And one of the ways they've been solving the problem is to pull members of their customer service team off of member-facing calls to call doctors and ask them to confirm their demographics. Like that's totally just robbing Peter to pay Paul, right? And it's worse than that because just good luck calling a doctor's office and having that conversation. But everybody does it, and it's hard to break the bad habit, I think, for a lot of these organizations. I guess I want to ask you, this is maybe a provocative question, but I think North Carolina is far enough away from where you operate, and you brought it up as an example. Like it seems like the perfect situation from a state Medicaid perspective to get a lot of this stuff right. I mean, you're moving from straight fee for service Medicaid to an RFP for managed care for the first time. And then it sounds like from your anecdote, like within the early stages, there's already some buyer's remorse there. Like, why isn't that the perfect opportunity to get this stuff nailed down and do it differently in the contracts?
You are so perfectly right on that, David. It's like any negotiation, I think, or contracting cycle, you have more strength and influence at certain times than you do others. And from a state or a purchaser perspective, that's going to be in that RFP/contract period where you can really be very specific about exactly what you want and make your bidders demonstrate that they can do it. The challenge is if you don't articulate those things at that point in time and you award a contract, then you're kind of stuck for that period of the contract until you have that ability to influence again and weigh in again. And I think that's something that we've seen across the Medicaid continuum, is just not that the contracts are poorly written. It's just they don't go to that level of detail because they expect these large companies to be the innovators. They expect, like, their name and their brand recognition is they're industry leaders, so they probably have better ideas than we do. I'm telling you, they don't. Like, they have a national plan and they'll put that plan in your state. They're not going to come in and say, we're going to do everything different here, because it's going to cost them more money. It's going to affect them on their profitability. And I think that's another aspect of the health insurance side, especially in the Medicaid space, that didn't bother me at first, but kind of troubles me now, is just this idea of for-profit entities navigating in a system with such low reimbursement to providers and all that, because they're still going to be responsible to their shareholders to make a certain price, to bring a certain percentage in. And that's not the way these contracts are set up. And the managed care entities are still coming into contracts thinking, how do I spend less money versus how do I do things really well? And I think that's kind of different when you look at the nonprofits, because we don't have those same pressures from the financial markets and from our boards. If we're in the 1% to 2% profitability rate, we can function on that just fine. But that's not going to work for some of these larger companies that are expected to return 15, 18, 20% to their shareholders.
Well, it's a little counterintuitive, but what I've observed is that you would expect those sort of Fortune 25 for profits to really be the fountains of innovation in the industry. I mean, they have huge venture capital arms and they're making investments and buying companies. But at least what I've seen in our little corner of the market, I actually think that the regional and the smaller plans are often able to be more nimble and make dynamic kind of IT strategic decisions in a way that the big ones aren't. And it's almost like the complexity of the surgery that's required to put in a new system. When you talk about a Centene or whatever, right? Like, I mean, the points that you've got to disconnect all the pipes in order to, like, slide in the new piece. It ends up being so complex that it just reinforces the inertia that's already there.
Oh, I couldn't agree with you more. I mean, and a lot of these, health plans have had the same systems around since the 80s and 90s. Like, they're built off old mainframe systems that's ultimately running their core. And the way I look, I mean, I spent my first 15 years in healthcare IT, working for companies like Cerner and Imprivata and others. I think we saw this in the hospital space, and I'd like to see when this evolution takes place in the health plan space. But if you remember, like, hospitals used to run everything soup to nuts. They used to manage their own storage. They used to manage their own email systems. And then finally somebody said, wait a minute, we're in the business of providing care. We're not in the business of managing storage. So why don't we manage the care of the patients and we outsource these functions to the people that are really good at these things? And I'm waiting for that to happen to health plans. I'm waiting for them to say, our core functionality, our core competency is this. Everything else, let's analyze and see if we should manage that ourselves or partner for that. Because I like the partner approach. I like it for a lot of reasons. First of all, I'm hiring a specialist to take care of something that they have 100% of their focus on. Second of all, I can delegate some of the risk I may have in that area if it's part of my contract. So I can create a value-based type arrangement with my contractors, or so we both have skin in the game. And I feel like in that model, I get an expert telling me how to do this piece of my business versus me trying to figure out amongst all the other things I'm trying to do. So I think that at some point in time, health plans may end up following that hospital kind of lead from the 90s into today, where they started pulling off all those non-critical functions and outsourcing them to specialists. I think that would be a huge boon, because then the health plan could focus on exactly what's most important, providing that that amazing experience for their members, and then working with treating providers in a way that takes advantages of their strengths, so they can make sure that those members are as healthy as possible.
Yeah, well said.
So I think what we're getting at a bit here is that sort of technology can be the foundation for making these strategies you're talking about effective. You really can't be effective at implementing these types of visions if your team is mired in sort of manual processes, sort of constantly chasing provider data accuracy, reworking denials, etc. And I was actually at a conference just last week in Illinois, where they've made really great strides around sort of resolving provider abrasion with the various MCOs there. One big innovation they made is sort of standardizing across the state a provider roster. And they've seen big improvements in provider data accuracy, um, payment of claims more accurately, etc. But just during my time there, I was actually shocked to meet some plans who I won't name names, but they do fall in that category of the Fortune 25, or I would even say the top 5 payer, that has still a backlog of 2,000 rosters. And I was like, oh my God, what are you guys doing? So just taking that as an example of, obviously, you can make these innovations to some degree, but if the payer themselves hasn't adopted the right technology to process these things, how do we, you know, come into these types of organizations and sort of advocate for change? What can we do to sort of, the people that are making the decisions about investing in these things often aren't the people feeling the pain of having to work the problem. So we often get in conversations with the folks who are really feeling the pain, but then we got to go alongside of them and sort of, advocate for them, work alongside of them to create a business case. So, John, can you kind of help us understand a bit better, what can be done to, be an advocate for change within an organization such as yours, or, even some of the bigger organizations that you've been a part of?
Yeah, that's a great question, Jake. And you know, I think it's even more fundamental than just if you have the wrong technology or the wrong approach, can you not execute on your business? I don't think you can execute on your vision. I don't think you can execute on your values. If your values as an organization is, we want to provide an amazing member experience, and you already have all a large quantity of your resources sucked up doing non-value added, non-member impacting activities, then you're not delivering on that. What I would see is, if I could come into an organization and say, you're using technology Y. If you use technology X, I can provide you with an increase of 10% of your workforce focusing on member issues versus focusing on these issues. That will allow you to get closer to your mission, your vision of providing that experience that you want to provide them. I mean, that's why we come to work, right? We come to work because we want to take care of people. We don't come to work because we want to, deal with the ramifications of having the wrong technology in place. So, I mean, I think it's no different than putting the wrong gasoline in your car. It doesn't matter if you have a Ferrari. If you're putting in the wrong kind of gas, you're not going to be able to leverage all that horsepower, all the value from it. And I think people don't connect those dots. I think that they don't see that by making the wrong choices in what seems like smaller arenas, you're stealing from your overall mission, vision, and values. So I think that there has to be a very quantitative conversation around costs, but those costs aren't always just dollars and cents. I mean, quite often they're those soft costs of saying, hey, if you can repurpose 10 people to do these other activities, what does that mean for your business? And I think that message will probably resonate more higher up the chain as you go. Hopefully, the leadership is aware of what kind of impact it would mean to be able to have 10 more people in the field or working with providers or working with members, and what kind of value that would bring back to the organization. I mean, that's how I think I would approach it, is try to connect from an intellectual standpoint, from the financial side, but also connect with that emotional standpoint of, we can take better care of people if we go down this path and repurpose people to do other things. And I think ultimately that's how we buy, right? That's how we make decisions. So if you look at the behavioral economics of it, there's that thinking fast and thinking slow. So the fast thinking is that emotional thinking. So maybe coming in and saying, hey, I can expand your client facing workforce by 10%. Okay, tell me how you do this. And then you go into the more like logical side. Well, if we do this and we do that, then we save you some dollars, we retask some people, and then this is how it actually functions and works out. So that's my perspective on it.
Jon, stepping outside the walls of the health plan, I mean, one of the cool things about your career, I think it's cool. I don't know if you think it's cool, but you've been on the government, on the regulator side, the government side of this business, and you've also been on the health plan side. And one of the conversations, it's a perennial conversation, but I think it has some legs in different ways right now, is are there benefits to the government, state or federal, taking more of a taking the driver's seat on some of these administrative simplification issues? And the one that got all the attention was CMS saying, hey, market, what if we did the Uber all everything provider directory, and that would solve all of these problems that you all have? Like, what should that look like? And whatever you may think of that, and the pros and cons of that, it's clearly a signal that CMS is kind of ratcheting up its attention to this issue. But Jake mentioned what they're doing in Illinois, which sounds like, I mean, it sounds so basic, right? It's like, hey, hospital system, you're sending basically the same roster to 10 different carriers, maybe in 10 different formats on 10 different schedules. Like, why don't you just send one somewhere? Or well, let's start. Why don't you just use the same template for all of them, and let's all agree? And we had someone on a previous webinar who drove that, and she just talked about the months and months of agonizing stakeholder give and take and negotiation that was required to do that. But it's so obvious that this is not a competitive advantage for any plan, right? Like, are you really competing on are you competing on the coolness of your roster template, right? Or how easy it is to connect to the SFTP site where you have to drop the file. And so there are other states where we're here. They each kind of have their own flavor, but there are maybe a half a dozen other states out there that are thinking about this, and trying to come up with small steps in that direction. I just wonder, are you cynical about that? Do you think that's a net positive?
It's a great question. First of all, I believe in little steps. I believe whether you're trying to change something in your life or achieve a goal or whatever, the little steps make up big steps, and it's much easier when you break it off into bite-sized chunks and little successes along the way, so you can keep that momentum going and moving the things forward. So you brought up CMS and some regulatory things, and I think one of the biggest challenges in the government space, in the space, is a lot of times the people that are in those spots making the regulations or whatever have never operationalized it.
Mhm.
And just the opposite, the people who are operationalizing everything don't really have influence over the policy. And
Mhm.
that gap between how a policy or regulation is written and how it is implemented is where you win or lose the game. That is one thing I have seen numerous times throughout my tenure of working with state governments, federal governments, is when they're not inclusive of the operational people when they're writing the policy, we get policy that can't be implemented or can't be implemented correctly or is implemented poorly.
Right.
But when they come together and you meet with the folks who do the work and they can help craft the policy together, then I think you can get something compelling. What I would say is I don't think in the United States there's a one size fits all for every market and every plan. I think that we need to develop flexible solutions that can be quickly adaptable to local needs. So I don't have a problem with like a set of core criteria that everybody has to meet. I think that's reasonable. But the solution for California is not going to be the solution for South Dakota. I mean, it's just they're two way different worlds, right? As we know, with way different needs, with way different members. But as long as we're all operating off the same idea that you need to have these data elements or these standards that we all talk in the same language or communicate the same way or have the ability to do some of that stuff. CRISP is a great example. I mean, they do just such a wonderful job. I had dinner with their CEO 2 nights ago. Heck of a good guy, and the things that they've done within Maryland to help with the Medicaid redeterminations and essentially serve as that hub to send these Medicaid rosters to providers dynamically. It's been phenomenal, and the power behind their solutions and their partnerships made that possible.
Well, I think, yeah, I mean, CRISP has really found a way to, from the very beginning. I mean, 15 years ago, the premise was, hey, this is an immensely competitive market, and it really started with hospitals that were competing over market share. But there's no question that there's the premise that there are certain things that we can all agree are better done cooperatively that are not competitive advantages. And you get people around a table, and the first answer is always no, I can't think of anything like that, right? Especially lawyers and executives. But they've been successful at that message, and I think part of the alchemy of that was the perception that it was driven from within the industry to start with, and it was organic and self governing, and the trust that was created there, in that case initially among hospitals that hated each other's guts in a lot of ways. Eventually, when the regulator stepped in and said, well, what about this other thing or this other thing, like there was enough of a fabric of trust that people said, yeah, okay, we can do that too, and there's not some catch. So anyway, I think that's part of what's going on in Illinois, which is really cool. They've done the hard yards.
That's cool.
So John, I think we'd be remiss to not further go down the road of what you hinted at earlier, which is sort of a modular no-code approach versus a sort of custom requirement, custom dev approach to managing provider networks. When you're thinking about sort of back to your current role and your strategy there, entering a new market, how would you think about leveraging something that would enable you to be more flexible? Can you help me think through that and then sort of like what the value is to you when, designing a new network and serving providers, serving members in that new environment?
Yeah, yeah, no, that's a great question. I mean, I would put that forefront as a strength of our health plan, or a demonstration that we are very provider friendly, provider centric, and member centric, as we can dynamically change, the experience for our members and providers according to their needs, very quickly. And we can also, respond to the state's request, or the purchaser's request, very quickly, if they decide to go down one route or another. Just that, we can be a good partner and support whatever opportunities that we see in the field independently of a state agency, or we can be supportive of a state agency going down one path or another. And I think that is one of the big differences I have seen, with some of these larger health plans, is instead of being a partner and I mean, they always use that language. Oh, we're going to be your partner. But as soon as you ask them to do something, it's like, no, it's going to take too long. It's going to cost too much money. We're not going to do it. I think having that mentality, having that engagement philosophy, builds that trust that then helps strengthen those relationships. And that's relationships both between the state and the health plan, the provider and the member, all up and down the road. So I think having that freedom, having that functionality to be able to be dynamic has a very big value price tag essentially along with it, that it brings a lot of value. Is what I mean by a big value price tag. The other thing, I would say, is I think that from a systems perspective, like I said, like putting on my IT hat again, I've been a part of companies that have done these one-off development efforts, and we used to call it spaghetti code back in the day. I don't know what they call it these days, but you thought you had like a stable release, but it turns out that all the way through their code, you have little one-offs here and there with a little comment on it to did this for customer A, did this for customer W, did this for customer X, and all of a sudden your code base now becomes riddled with these little one-off sections. And when you want to do transformative things, you can't, because you need all these other little lines of code spattered out throughout your code base, and you lose flexibility, you lose that functionality to be able to do it. That's why I've always been such an advocate of just the opposite approach of saying, let's put the core functionality into the code base and then provide you a configuration option so you can turn on and turn off features at a granular level. That's where the power comes in to configure and customize a solution for a customer or a state or a member or a provider.
And putting on sort of our health equity / innovation hats for a minute here, what are those type of tweaks and sort of changes that you foresee, within your market, but maybe even nationwide? Like, what are those new things that are coming at you guys that you need to be able to accommodate for?
Oh, sure. I'll give you a great example just off the top of my head, obviously. In my state that I was Medicaid director, we had four Native American tribes. They're very small tribes. They're not really engaged. They're primarily part of the Indian health system, but they do engage a little bit with the Medicaid side. You look at a state like Alaska, there are dozens of tribes that all have their own unique cultures and their own unique needs. There would be things that I would imagine they would want to see in Alaska on their provider directories that we wouldn't have to do in Kansas, because there's not a consumer that's demanding it. And even as you look through the other states, the demographic and the makeup of those communities and of those citizens will drive the need for very customized things. And that's what I love about something like this, is that you can have one single platform that can work everywhere, and you can make those changes without affecting every other market. You can keep Kansas the way Kansas is, and have Alaska be the way Alaska is, and California be the way California is. And those things don't step on one another, cross over one another. They can exist independently and yet still cohesively a part of a as part of your data provider data strategy.
Absolutely. And we're seeing new data elements. Like a common story we hear from our customers is sort of along the lines of what you said, but different states are adding new data requirements all the time, almost every other month is what I'm hearing at certain points. And a lot of it is, data that would enable plans to fine tune their services to the members and to serve their members better. But if you don't have a solution that can take that information in, surface it, do what they need to do it with the claim system, et cetera, then it becomes this manual rabbit hole of chasing down the data, chasing down providers, adding extra abrasion to these providers who are already, under a lot of stress, having a lot of additional administrative burden thrown at them by the plans. So how do we change the paradigm and think differently about implementing tech that eventually allows the plans to be more nimble and compete better and serve members better?
Yeah, we have a really interesting view of this working with the state-based exchange in Washington State. So we're getting the rosters for I think it's 18 different 18 different plans across like 11 carriers. So it's managed Medicaid and the QHPs. And we've started to slice and dice the data that we're seeing coming in from all of the carriers. And the consistency at which they're providing some of that sort of real D stuff, right? Gender, accommodations for disabilities, languages spoken is just really all over the place. The other thing that we've seen, which you kind of expect, but you see it in this data set, is you have one practitioner who is attributed across the 15 networks or whatever to 10,000 locations. We actually sort of scatter plotted the attribution of practitioners to location, and they're like they're hugely concentrated in the like 1 to 10. But when you get to 10, it's even 10 is like, okay, somebody really practicing at 10 different locations. But then there's still significant numbers out there, 20, 25, 100. And then the really, really crazy outliers. And that kind of tells you what you need to know, right? From a consumer perspective, that's someone who's shopping for insurance on the exchange. They're slicing and dicing the choices that they have by a bunch of different things, including availability of providers that meet their needs, either because they're close or they speak the right language or whatever. And you just cringe because if they pick up the phone, that they're gonna run into the buzzsaw. So I think it's kind of a meta. Like it's a meta situation. It's a meta analysis that we're able to do in that unique situation that I think sheds a lot of comparative light on what's really going on in those networks.
Yeah, guys, I think I'm not seeing any Q&A come in, but I'd encourage any of the attendees here to drop any questions you have for Jon and David, either in the QA or in the chat. I'm monitoring those things for Q&A here, but if I don't see anything else, I feel like we covered a ton of ground here today, and I learned a lot, especially. So, Jon, really great to hang with you and chat it up, and David, likewise. Any sort of parting words or ideas that you guys want to throw out there before we wrap up?
I would just challenge folks that I've seen when it comes to the space, this directory space, that people see it as just something to check the box with, and it just isn't. It's extremely important. It affects every part of the care process, And it should be one of your strengths. It should be something that you should advocate for and be proud of and help you become more efficient, both connecting members with resources and getting your claims paid accurately and timely on the back end. It all starts at the beginning. It all starts with the experience. You can earn somebody's trust when they're anxious. They know they have a health problem. They're trying to find a provider. And if you make that experience an easy one, they're going to remember that. But if you make it miserable and you make them call or you make them try to find somebody else, you're going to lose a member next time open enrollment comes around because they're not going to want to do it again. So let's turn this challenge into a strength. I think the members deserve it. I know the providers deserve it for all the hard work they do. And the health plans need to execute better on it.
Those are words of wisdom. I'll let Jon have the last word here. Jon, I really appreciate you taking the time to chat with us. This has been great.
You bet, fellas. You guys are awesome.
Well, thank you so much, Jon. And the recording, I will be sharing the recording out to the folks who made it and the registered folks as well. But as always, thanks so much for joining us at Interoperability Roundtable, and have a wonderful rest of your day. Happy Friday.
Thanks, guys. Thanks, everyone.